everyone with an interest in NASH, or more broadly, fatty liver disease, source up. Season 4, Episode 8 of Surfing the NASH Tsunami. Our look at digital therapeutics starts now.
This week on Surfing the NASH Tsunami.
I can envision a future 10, 15 years from now where computers are treating very simple, delimited diseases in a very well-designed pathway that is augmenting the ability of a doctor to deliver.
When these patients that have low FIB4 or low liver stiffness are being sent back to their primary care physician, the idea is that they need to be enrolled in an effective lifestyle intervention.
Patients feel like they are in charge of the changes that they are making, and they have a tool that can support them in that journey.
Instead of talking about this as digital therapeutics, this is simply going to become almost the broader sense of digital health with a lot of things hanging off of a lot of different levels.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researcher and key opinion leader Dr. Naim Alkhouri, Better Therapeutics Chief Medical Officer Dr. Mark Berman, and ChronWell founder and CEO Dr. Joseph Rubinsztain as they discuss the future of digital therapeutics. This week on Surfing the NASH Tsunami.
So this is an exciting podcast for us. We have two guests we've never had before. We have a topic we've never covered before. We have Naim back with us. Naim's not been with us for a little while. Naim, how are you today?
I'm very good. A little bit sad about Super Bowl. I did my residency training in Philadelphia, so I was rooting for the Eagles. But otherwise, life is good.
Naim, I was telling Jörn about the outcome of the game a little bit when he got here early. He asked if we're all resolved in our mind about the defensive holding flag with 1 minute and 48 seconds to go. And I think the answer is Jörn doesn't know Philadelphians very well. They'll be resolved about that in 25 years. But yes, it was a great game. Disappointing to have lost. Jörn, how are you today?
I'm great. My personal highlight, we'll get to that later, but it wasn't football. I wasn't able to follow the game. It's always a hassle in the middle of the night.
And Louise is doing this while the Merseyside derby is going on between Liverpool and Everton, so I have to give her credit for that, if nothing else. Unless you have the game on a second screen while you're recording, Louise.
It doesn't start till 8 p.m. here, so we're a little bit early for that. But given that Liverpool are the bottom statistically team at the moment with 1 point in 5 games, I'm just lucky this year we're out of relegation. So I'm not talking football anymore.
Given what happened to Tottenham this weekend, I might not either. I was hoping the Eagles would win the Super Bowl, so I'd have one good sports story, but whatever. And then let me introduce our audience to a new guest and a guest we've had before, but only in an extra set. The guest we've had in an extra set is Joe Rubinsztain from ChronWell. Joe, how are you today?
Excellent, Roger. Not as much of a sport fan as anybody else, but since I lived in Philly, I'm also disappointed a bit.
From what you're wearing, I'm assuming you're still in Park City, which means you're skiing, which means I'm jealous. Do us a favor, take a minute or two and tell our audience a little bit about yourself and your history and what you're doing and how you got here. And then at the end of that, please, one thing that they wouldn't know or necessarily assume about you if you didn't tell them.
Well, I am a physician by training, but a computer scientist at heart. I graduated as a medical doctor in Venezuela back almost in the 80s, in 1992, and have been doing electronic health records ever since. Long time ago, started a company that does electronic health records for specialties. That was called GMIT then, and we sold it in 2015. And ever since then, we've been looking at what is the next thing that computers can do for medicine beyond just storing information, is how to use that information. And we've gotten very deep into understanding how to use that data to deliver care in very particular conditions that cause significant expense in the healthcare system. And that's a new company called ChronWell. So we're building digital therapeutics for non-alcoholic fatty liver disease, in particular NASH, and some other metabolic diseases. And one thing that people don't know about me is that English is my second language. I usually was trained in Spanish, and it's a really odd combination of having a Jewish guy come in from a Latin American country who who loves skiing doesn't necessarily sound that Latin American to me.
Joe, I was thinking you could be your own doppelganger. If there's one of you in the Southern Hemisphere, one of you in the Northern Hemisphere, that would be perfect. That's great, and thank you. For those who do or don't remember, when ChronWell launched Liver Healthy with Modify Health and with EchoSense back 2 years ago, Joe was part of that launch extrasode along with Jerry Mabry, who now works for ChronWell, and Hagen Jordan from Modify Health. So welcome back, and welcome to the main stage. Our last guest today is Mark Berman, who's not been with us before from Better Therapeutics. Mark, how are you today?
Roger, doing great. Super excited to join you and to meet everyone here.
Excited to have you with us. So same drill, 1 or 2 minutes about yourself, how you got, what you're doing and how you got here, and then a fact we wouldn't know about you if you didn't tell us.
Absolutely. So like Joe, I'm also a physician by training. I trained as a primary care doc in internal medicine, primary care, and population medicine. But my true passion has always been around nutrition and behavior change. That's what brought me to medical school and what I've tried to make a career of post-residency. And for the past 10 to 15 years, I have been working clinically and also in a variety of digital health startups to help use technology to help foster behavior change. And about 7 or 8 years ago, I found myself with an exciting opportunity to join what was a startup then in San Francisco, which we now call Better Therapeutics. And we're focused on building digital therapeutics to treat cardiometabolic disease broadly using a combination of cognitive behavioral therapy that we've developed in-house to help facilitate and really target diet and lifestyle change in a variety of indications. I'm going to build on Joe's theme a little bit, share that I too am a little bit of a mixed up individual. I was born in the Southern Hemisphere in South Africa. I grew up in Canada, and so I love very contradictory things, also like ice skating and Marmite and things like this. And that paired with the fact that I'm also on the dyslexic spectrum makes me kind of an unusual guy to work with.
It strikes me this might be the first time in the history of this podcast that I am the only American-born person on this podcast. That does not happen very often, if at all. But that's fantastic. And I guess that would be my surprise for the day is I actually am American-born and not nearly as much of an anomaly as you, gents, are. That's fantastic. And I'm looking forward tremendously to this conversation. Just to kick off, one quick round of icebreakers, one good thing, personal, professional, that happened in the last week. Jörn, you already signaled that you had a good one, so why don't you lead off?
Yeah, I went to the football game, local team here in Mainz playing Augsburg, which is like the middle field of the German soccer league. It was a good 3-1. We're standing up high in the ranks and waving our flags, and it was fun with the girls. So that was a great Saturday afternoon.
We're proud of you. We're proud of you to have a football team that won this weekend.
Yeah, and I haven't been for a game for a long time. So really taking the kids, I think, is the rewarding thing here.
Well, Louise and I will take credit for prodding you to do that with our incessant football talk on podcast.
That could be my success of the week, getting Jörn to a football game. Other than that, it's cleaning my fish tank out, which I haven't had time to do for ages. My fish are looking a lot happier.
Congratulations to your fish.
Well, I did join my wife in going out to Park City slopes and skiing a little bit in a Bluebird Day, which seems to happen very often here in Park City. So that's a personal highlight.
I guess I'll go next. So I just learned that my 8-year-old is into badminton this week, and I had no idea. She's been playing at school, and it was so cute. We bought a badminton set, and we played a tournament over the weekend. So that was very fun. And then tomorrow for Valentine's Day, I'm getting myself the gift of hepatoscope. And this is a new FibroScan-like machine that I will have in my office in Chandler. I love new technologies, and I like to be involved in things even before they're mainstream. So this is my Valentine's Day gift, is a new hepatoscope.
So a note for one of us to reach out to Donna Cryer and Jeff McIntyre and suggest to them that next year Global Liver Institute has to do a campaign, Valentine's Day is for your liver. I like that idea, Naim. It's got a lot going for it.
Similar highlight with my 8-year-old, we managed to take her to the ballet for the first time outside of, the Nutcracker, and she stayed awake through the whole thing, which was a big, big victory, and actually loved it. I think her highlight was a gentleman urinating in the parking lot on the way out. But aside from that, it was a really lovely experience for the family.
Quality date.
It is. So I didn't have any highlights. Tottenham was awful on Saturday and got 2 players hurt. The Eagles lost the Super Bowl. And other than that, nothing particularly exciting. But Mark, you remind me, my wife has a passion for ballet. And when we met, she had 6-row center orchestra seats for the New York City Ballet, which are really hard to get. And we've had them ever since. But the first time she took me, I did fall asleep. Over time, I learned to love the ballet. I don't sleep anymore. So your daughter has one up on me. And I will let that be my good news for the week, is that your daughter outdid me in terms of response to the first ballet in New York. It's not infrequent to see the kind of thing you described on the way out, but it didn't happen that day. So with that, let's get started. We've talked on this podcast intermittently in lots of different contexts about the idea that digital life, all things digital, are becoming increasingly important in medicine. What we've not done yet is taken the time to focus on any of that. So today's Focus Day, or first Focus Day, focusing on digital apps, their ability to drive outcomes and critical success factors in their proper use and deployment. So to that, I'm going to ask Mark to talk about Better Therapeutics, and maybe with a little assist from Naim, who did some of the research for him, and then we'll take questions, and then Joe and Louise will go on from there. Mark, your floor, my friend.
Thank you, Roger. Well, by way of introduction, I'd say one of the insights that got us started in this work was the idea that so much of cardiometabolic disease, and that includes NASH and NAFLD, but also includes cardiovascular disease, type 2 diabetes, and so on, are rooted in behaviors that are adopted society-wise. And so much of the burden for those conditions falls not only into specialty clinics, but also to primary care practices. And the reality is that although the guidelines speak very consistently and very intently on facilitating behavior change, this is something that's easier said than done, and that practices and clinicians don't have the tools, the training, the reimbursement to really affect behavior change and therefore affect disease burden, whether it's in NASH, NAFLD, or other cardiometabolic diseases. So Better Therapeutics was created to help address that by developing forms of what we'd call prescription digital therapies that can be delivered by a provider, by a health system, prescribed, and offer intensive forms of structured lifestyle change or behavioral therapy to help the mainstay of guidelines around behavior change be implemented in a scalable and efficient and effective way. We've done work in other related indications, hypertension and type 2 diabetes. Last year, we announced the results of a pivotal trial in type 2 diabetes, which showed that you could use a prescription digital therapeutic to have clinically meaningful changes in blood sugar control. And in the midst of that, it also became obvious to us that type 2 diabetes is not the only indication that behavioral therapy is needed. There's a massive unmet need that I think you and the other guests on the show have really done a wonderful job articulating, the massive burden in NAFLD and NASH. We knew from our clinical experience that the same approach that you could use for type 2 diabetes or other conditions could also be applied effectively to NASH or NAFLD. And so we set out on a course to try to generate the evidence for that. We had the pleasure of partnering with Dr. Alkhouri, Naim, and his group at the Arizona Liver Health to run a feasibility study in which we used what we'd call a generic version of our cognitive behavioral therapy, one that wasn't necessarily specifically targeted to NASH or NAFLD, but was targeted more broadly to cardiometabolic health in general. And we ran a feasibility study over the course of 3 months at 2 sites at Naim's clinics to recruit participants who would be generally found in a specialty care clinic with a spectrum of NAFLD and NASH to see if they would use a digital therapeutic to understand what the effects would be on the liver and cardiometabolic health in general, and also to help gather data for us to then turn this into a more specific form that would benefit patients for NAFLD and NASH. And we announced the top-line results of that study last December, so just a month or two ago, and we had very exciting findings. We found that the majority of the patients were able to show improvement in liver health. We focused primarily on MRI-PDFF as the main outcome measure. We saw about a 16% relative reduction on average, with a peak reduction of about 64% in a patient. And I think some of the most notable findings, and I'll ask Naim to chime in on this as well, is we saw consistent improvements across a range of other measures of liver health as well. We saw a mean ALT change of 17. We saw in those with elevated ALT, we saw a 23 milligram per deciliter decrease. We saw a 20% reduction in FAST scores. And we also saw a steady weight loss in the course of the treatment, which is consistent with the nature of making behavior change in a gradual and progressive way. And this is what we've seen also in our other studies, that what's different about behavioral therapy versus a drug is that the onset is gradual, and it is, if done well, it can be progressive, and if done well, can be sustained as well. And so we saw that signal in the study as well. Because this was also in some respects a usability study, we were excited to see a few other things. One, that there was a dose response. People who used the therapy did the best. From a safety perspective, we didn't see any device-related adverse events in the context of patients who were on multiple medications, who had multiple other related cardiometabolic
metabolic comorbidities. And so that too is reassuring, because as we understand the evolving landscape of NASH and NAFL, is that it's probably one that will mirror other diseases like type 2 diabetes, where there are multiple agents that will be used. And a key concern for physicians and patients will the ability to add additional therapies without causing untoward side effects. And then I think finally, the last thing to say is from a usability perspective, we saw very high engagement, but 94% of the patients were still using the app at 3 months, and they gave very high levels of satisfaction, 75 on a net promoter score, which is considered an excellent score relative to satisfaction. So for us, it was a successful proof of concept, our first study in NASH and NAFLD, hopefully not our last. And from this, we'll be hopefully moving quickly towards a more robust randomized control trial to demonstrate that this has a place alongside other therapies in NASH and NAFL. So those are the quick highlights. Naim, maybe I'll turn it over to you to see other things to add.
Yeah, thank you, Mark, for the excellent summary. First of all, I want to let you know, Roger, that Mark and his team found me on your podcast. So basically, you can take credit for everything that Mark said. If it wasn't for you, probably we wouldn't have done this proof of concept study.
We need commission.
No. I'm going to just comment first on digital therapeutics in general, and then I'll get to the specifics of the proof of concept we did with Better Therapeutics. As you guys know, I mean, not all apps are created equal, and there's a lot in the space. So you have apps like the Noom app, where we actually did another proof of concept based on improvement on FibroScan. Noom is something that our patients can download, pay a fee, and then you get access to the app. But this is not a prescription digital therapeutic. You don't need a physician to prescribe it. It's not going to be covered by insurance. It's a good approach for some patients, and we will have results that hopefully will present this summer with the Noom app. And then the second category is prescription digital therapeutics, and this is the Better Therapeutic app. Again, this will have to go through a rigorous evaluation process. You can get FDA approval for a specific indication. Mark can tell you more about their diabetes program that's sitting with the FDA. But, to get something to be FDA approved as a NASH therapeutic, we really still need to figure out what the FDA will require from a prescription digital therapeutic, where there is really no major adverse events. You're not worried too much about safety. Do we have to do biopsy and histology improvement? Can we get away with NITs and non-invasive tests? And I think it's a conversation that needs to happen. But I think the risk-benefit ratio is very different than a new drug. And then the last category is what Joe is doing with ChronWell, where, you have the app, you have the digital therapeutic, but also they have boots on the ground, they have a team, and I'll let Joe explain the approach more. But we're also excited to announce that at Arizona Liver Health, we implemented ChronWell now as part of how we manage patients with NASH. It's still limited to certain insurance providers, but this is something that is covered by insurance, and the team helped them get a scale at home. They help them with lifestyle intervention. They have the app on the phone, so it's a more comprehensive approach. So much is happening in this space. So going back to Mark and Better Therapeutic, it was a very exciting proof of concept, and I really enjoyed working with his team because they listened. We developed the protocol together. We came up with the inclusion-exclusion criteria, and they really were willing to invest in generating data with MRI PDFF, which is costly, but I see it as probably one of the more accurate NITs, especially for a short-term study. 90 days, you cannot really look for fibrosis improvement. So you have to look at things that can change. So we had ALT, AST, we looked at PDFF, and we also looked at the FAST score based on the FibroScan that includes CAP, liver stiffness, and AST as a more global way to assess for liver health. And the signal was positive. We saw a reduction in MRI, PDFF, ALT, and the FAST score with weight loss. What I liked is it was minimal involvement from my staff. So basically, we signed up the patients in the initial visit. They had the MRI, and then they're gone for 90 days, and then they came back for the last visit and repeat MRI and labs. And the fact that, within 90 days, using an app, a digital therapeutic, we were able to see these results. I was very encouraged to see the signal. The feedback we got was positive. They enjoyed being on the app. But as Mark said, it's really all about engagement, how much time you spend, how many articles you read. The more engagement, the better weight loss, fat reduction, and improvement in liver enzymes. This is something that, I want Arizona Liver Health to be a leader in, is really partnering with digital therapeutic companies and being able to conduct conduct these proof of concept studies where we help with the protocol design and the execution of the trial. And even we help the team also with the analysis of the data and what the statistician needed to look at. I think the future is going to belong to digital therapeutics, maybe alone for patients with NAFLD and maybe early NASH, but also in combination with the new therapeutic agents that we are developing. The first wave is going to be with resmetirom, but also even with more effective weight loss approaches like semaglutide and tirzepatide. We learned that if you stop these medicines, patients tend to gain weight afterwards. So I think we need ways to maintain the success we obtain with these therapeutic agents and potentially be able to wean off some patients so they don't have to stay on drugs for the rest of their lives. I think another piece is maybe insurance providers will require a structured lifestyle intervention for patients with early NASH before they approve therapeutic agents, and maybe we can provide that answer using digital therapeutics instead of having to refer to a dietitian and wait a few weeks before they have, the first visit, and then they have to do the whole program for a few months. So we can maybe provide the app early on, check that box that we did a lifestyle intervention, and get them on the drugs. So a lot to talk about, but this is my spiel on the whole field of digital therapeutics and what we're doing at Arizona Liver Health. And I am a believer, and I think more to come on this in the next few years.
Naim and Mark, congratulations. It sounds great. And we'll want to hand it over to Joe just to learn how, he builds this in his care provision at Arizona Health. That sounds great. It's too bad you're not based in Germany, Mark. I'm happy for Naim that you guys paired up. It really sounds like a baseline therapy to me. It's something we've been discussing. How can you engage and keep patients on it? And also an endpoint that came to my mind, and you might have been discussing this, is obviously quality of life, where you set the positive aspect of engagement. And I think for something that has a positive risk-benefit ratio, as you highlighted, Naim, is could also be a valid endpoint.
I found it fascinating, and it's obviously something that I engage with a lot, but from a non-medical side in one aspect. Did you find the patients felt less medicalized? Because one of the things that I always find and struggle with is once we introduce patients to a medical pathway, there's the patient role, very well documented, very well evidenced, and people don't want to be told they've got yet another thing wrong with them. However, engaging in digital technology seems to do the opposite. I can do it on my phone, I can do it there, and I can be normal person still working at it. Was that something you gained any feedback on in patient experience or engagement levels?
Yeah, absolutely. I'll comment on that and then see if Naim has something to add as well. But one of the consistent things we find in our work is that patients often express a real appreciation for the nature of the engagement. And specifically, they really appreciate what might be characterized as a non-medical approach in terms of not being told what to do. So really, the way our product works is by providing a therapeutic construct that doesn't tell someone exactly what they need to do and what they can't do, but really shows them a direction that they can move into that is going to be supportive and healthy and helps them move at the pace that is right for them and as quickly as possible. And so the experience that is often reflected is one that patients feel that they have more control over their life. They typically do report an improvement in quality of life. That's been found consistently in our studies, as was found in this as well. And I think that speaks to the fact that, patients feel like they are in charge of the changes that they are making, and they have a tool that can support them in that journey. And that the aim is not just to treat a number, which is important. It's important for the numbers to improve, but really it's only becomes sustainable if patients are making changes that make them feel good. And that very much comes through in the day-to-day experience. They express a lot of appreciation, for example, to the physicians and clinicians, in this case at Arizona Liver Health, for providing that opportunity to have that experience.
Louise's question raised one I'd like to ask before we go on, which is in your literature, you talk a fair amount about the use of CBT. And CBT is one of these acronyms that I think a lot of people hear the acronym, but don't necessarily understand exactly what the premises are or how it works. I'm a big fan. I have a family member who, at a much more severe and psychiatric level, figured out how to put their life together with the aid of CBT. So it would be great if you just take a couple of minutes and explain what that is and how that fits into this. And then after that, we'll go to Joe.
But we'd love to. So CBT, cognitive behavioral therapy, really came about in the 1960s and is now considered the gold standard for helping people make meaningful and clinically meaningful behavioral changes. When most people hear CBT, they think about its application to anxiety and depression, post-traumatic stress disorder. These are, gold standard approaches to use CBT. But two things are not widely appreciated. One is that CBT has evolved since the 1960s. It includes a lot of newer forms of CBT, things like mindfulness-based therapy, dialectic behavioral therapy, acceptance control therapy. So when we use the term CBT, we're usually using it as an umbrella construct to think about all these evidence-based approaches to changing behavior. And the second thing that is not widely known is that CBT, because it has proven so successful in any of the psychiatric conditions, has been applied to a growing number of conditions. And for the past 10 to 20 years, has been applied successfully to cardiometabolic conditions like type 2 diabetes and heart disease and NASH and NAFLD as well. However, the most common approach is to use CBT to treat things like depression and anxiety, because these things are often comorbid with cardiometabolic conditions. And so it turns out when you treat the anxiety and depression, the diabetes, for example, gets better as well. In our case, we thought that there was room to take the concepts of CBT beyond that and actually use the principles of CBT, which really can boil down to the idea that behaviors are ultimately generated by the brain, that what we do for a reason, and it's because of the ideas and the thoughts and the emotions that we have about the choices that we're making that actually drive behavior. And you need to make that process or that awareness conscious in order to offer and reframe ways to make thinking about behaviors more helpful, and then to figure out how to gain the skills that you need to put those new ideas into action. So in our approach, we've leveraged the principles of CBT in that broad umbrella sense, but we've also specifically worked to develop a form that targets behaviors around diet and exercise and other lifestyle behaviors beyond those around mood and anxiety.
Thanks. That's a great answer. And this has been a really helpful last 20 minutes, I think, talking about the subject. Let me now turn to Joe. And Joe, tell us a little bit about ChronWell and how that fits with this paradigm and what's different about it and kind of how you see.
Thanks, Roger. It's really interesting that when we started back in 1997 to do electronic health records, it was just an idea. A lot of people didn't get it. Why? I have a piece of paper. I don't need a computer to go through this process. And today, when we're starting on this concept of a specialty platform that has a core computer model, some iteration today calls some of that digital therapeutics in particular. We're still a little bit in the 1997 wild west of EHR, but for the new generation. So when we look at the problem, we try to get a broad perspective and understand, what disease are we dealing with? What is the level of awareness of the disease? Who's interested in solving the problem? And how do people get paid to solve that problem in particular? And so that's the reason for which we believe that digital therapeutics only forms a piece of the pie of the solution. And we think that you need to expand the concept over to a whole-blown platform that allows you to find those patients that are at risk for the disease, that allows you to automate the service of those patients so you don't overburden a doctor that's already overburdened, that you find a monetization mechanism that payers agree to pay for results and providers agree to be paid for reasonable service that is good value of their time. Obviously, you're always looking for results and outcomes. That's a given. And then, beyond the cognitive behavioral therapy, how do you interact with the new pharmaceutical agents that are coming on board? And how do you deliver beyond CBT into education, into remote monitoring, and into other areas that actually keep an ecosystem running? Now, what I'm going to say is a little bit controversial is, now you can see that ChatGPT is speaking like an intelligent human and even passing board tests, right? It doesn't necessarily mean that the computers will take over for humans, but it's starting to mean that they can speak like humans. I can envision a future 10, 15 years from now where computers are treating very simple, delimited diseases in a very well-designed pathway that is augmenting the ability of a doctor to deliver. Because if you look today at who's really dealing with NAFLD, it's very few people. In our observation in the field, primary care providers have less than 1/10 of the patients detected with the condition. Insurers in particular are not necessarily very interested in dealing with people with NAFLD that are not in advanced stages because commercial insurers are changed every 12 to 18 months. So the concept of who's going to pay for a digital therapeutic is a real interesting one. Insurers are certainly interested in late stage diseases unless it's a long-term insurance. And so solving the equation for who wants to take the service, how much value you're going to provide in terms of outcomes versus cost, how do you get reimbursed, and what message needs to be delivered to which player in the field is the problem that we're trying to solve. We do believe, for example, that in theory, a digital therapeutic can be approved by the FDA as a prescription digital therapeutic, which means, yes, you can prescribe this program for this disease. And then once you have that battle fought, you have to go fight the battle with the insurance to figure out, who's going to cover it, which formularies are you going to be in. And you're seeing some companies come in and out of formularies very often. So I often wonder if the phrase digital therapeutic will not change very soon to something a little bit different. But the core of it is have the computers do the most amount of work behind the scenes to find the patients, to make sure that they're thoroughly risk stratified, to deliver treatment on the fly, to keep the doctor informed, to coordinate care, to monetize on the service because people ultimately need to be paid for it, and ultimately to deliver a comprehensive service that covers the full spectrum of the disease, including testing, including medications, including remote monitoring, and all those other things in general. So we have that controversial view of more a digital platform than a digital therapeutic per se.
Joe, from my perspective, you mentioned 2 or 3 things that are crucial, and in my daily liver clinic are really head-on, I think, because the patients are not identified outside of my area, and I think that's a major loss of society to be able to apply a preventive measure. That would be a big first step. There's not enough physicians to deal with all these patients with fatty liver, and again, preventive mechanisms could be best here, however you apply them. So I very much buy into your suggestions on how platforms, programs, or however you call them, could augment, and I like that term, augment the physician, because in the end, we're going to have someone with advanced disease. He needs active management, got to see a physician, make a treatment and a diagnostic decision. But here, really, the support of a platform, I think, comes in handy in this disease where there's many patients, nobody's identified today, and I think there's a big unmet need. So congrats.
Thank you. I think, trying to circle it around in particular, we are partnering with primary care providers, with specialists and hyper specialists like Naim to understand all stages of disease. And how do you emerge patients from the underground and find that they do have the disease and need attention? How do you enable that network of physicians to take care of the right disease stage at the right time? And then what is the type of product that you generate for each layer of the care platform, right? So the reason I'm bringing all of this complexity is because as we start thinking about new generation tools to take care of conditions like NAFLD and NASH, we need to think really broadly about activating the ecosystem and making it really zero friction for the healthcare provider to utilize.
This is becoming more and more important as we have all these algorithms now by different professional societies, from AGA to ACE, and more recently the ASLD new guidance document on the management of NAFLD. If you look at these algorithms, they are all trying to identify patients with fibrotic NASH that need to be sent to a specialist to be considered for pharmacologic treatment. But the idea here is that when your FIB4 is low, when your liver stiffness is less than 8, you still have fatty liver disease, which is not good for you. And I think Louise will agree with me on this one, that fatty liver is not good. Sometimes we have to prioritize the sickest patients first. But when these patients that have low FIB4, low liver stiffness are being sent back to their primary care physician, the idea is not that we're going to wait, 2-3 years without doing anything and then just repeat the testing. The idea is that they need to be enrolled in an effective lifestyle intervention. And I think for all these patients, what Mark and Joe are doing, this is exactly the kind of intervention that could be scaled to a large population that I think is going to go back to primary care physicians with expectations. They're not going to say, oh, okay, I was told I don't have fibrotic NASH, I'm okay. They're going to be like, I was told I have fatty liver disease. I know it's not good for me. Some of them will have family members that progress to cirrhosis and they know what could happen. So having a structured digital therapeutic or platform like what Joe has is very helpful. The second piece is even when we start new medications, let's say resmetirom, obeticholic acid, I really see an opportunity for combination digital therapeutics with traditional therapeutics and see if we can increase efficacy also. And these are clinical trials that are waiting to happen. And I hope that the pharma companies will actually act on this in the near future. And I can envision trials that you could be randomized to traditional therapeutic and then compare it to a combination digital plus a traditional versus placebo, and maybe no placebo also in the near future once we have, standard of care available that's FDA approved. But these are all things that I think, they can fill the gap.
Everything that Naim has said there resonates with what I was going to say. And obviously the strength sometimes is to go back now to the patients that we did discharge to primary care with just fat within the liver, not fibrosis, get them with the digital technologies. The one thing that struck me with Joe's initiative specifically and the AI use of the platform is the strengths of comorbidity management. Currently, we have patients seeing diabetologists, cardiologists, hepatologists, and that multi-appointment system means that they drop out of the system or they disengage with one or the other. The sort of strength that I'm hearing from the future, or particularly what you've got there, Joe, is that this could be used within that model to streamline the basic areas where we have the same outcomes. We want to improve diet for the patients for cardiology. The heart is a muscle. It's never eaten or digested anything in its life. So we need to write that into the pathway. We're changing your liver and gut health to help your heart. The same with diabetes. Do I take it that you can share that information across cardiology, endocrinology, hepatology, so all of the physicians in that patient's care and nurses, because they do a lot of it, can see that same digital output?
That's an excellent point, Louise. I do have a story for you that I think is going to hit home with everything you just said. We knew that fatty liver was a disease that lives under the surface and that very few people are aware, including providers. The level of awareness for providers is much lower than what we think. We have observer's bias. We know what we're talking about because we're focused on it, but the person that's focused on 1,000 diseases considers this a low-grade disease unless it develops into NASH. And so when we approached several primary care providers, all of them in unison came back and said, I'm not sure I'm interested in creating a liver health line. This is a disease that's obscure and I'm not even clear how I'm going to get it reimbursed for managing. I know it's important to the patient, but I've got more pressing matters. So we had to go back to the table and try to understand, what does the core look like? And it was essentially a metabolic core. And when you're looking at a metabolic core, you're going to look at, diabetes, hypertension, dyslipidemia. You're going to take a look at obviously NAFLD in particular. But when we reintroduced the product as a metabolic platform, a metabolic health platform, the uptake was immediate. They were not interested in dissective care. They were interested in integrative care. And that conversation happens to be the same with cardiologists or with endocrine or with nephrologists. The issue is that when you look at specialties like gastroenterology and cardiology, the majority of their revenue here in the US comes from procedures. And given the fact that this is a longer term approach and that doesn't necessarily have a clear pathway to reimbursement, they're going to take a secondary position to interventional procedures that carry more importance in the risk scale and the financial scale as well. So you're kind of stuck between a hard rock and a wall trying to push awareness for metabolic health that seems to be mainly in the realm of the integrator, which is the primary care provider.
So, Joe, I think that's a fascinating point. I'm going to turn back to Mark in just a second on that point, which is I put on my business head as I'm listening to this, and I keep thinking of a term that people don't use a lot now, but used to 20 years ago, which is disintermediation. The idea that by bringing new levels of data into a process, you can change the power structure by taking out certain levels of management or in the supply chain or whatever you're talking about. Mark, when I looked on your website, it struck me that while you've got processes going on in 4 different metabolic diseases, they don't feel that different to me from what you guys have on the website. Am I correct in assuming that fundamentally, if you take your diabetes program and you give it to patients who have both diabetes and NAFLD or NASH, that you'll see effect on both?
The study that we ran with Naim was a proof of concept where we used effectively the same product that we use for our type 2 diabetes study for exactly the same reason that Joe has mentioned, that when we're addressing the underlying behaviors for any particular disease, whether it's NAFLD or NASH or diabetes or cardiovascular disease, the underlying behaviors are very similar. And so our thesis has always been that if you can build a form of support or therapy that can address those behaviors, you have the ability not just to target one condition, but to target multiple conditions simultaneously. And so, for example, in this, and we've seen this this across studies where you have a type 2 diabetes driven study. And so these patients all have type 2 diabetes, but they also have hypertension and hyperlipidemia and NASH and NAFLD, and you see improvements in multiple different areas. So that is exactly our thesis, that it's one platform that can be applied very broadly to a pretty broad range of cardiometabolic spectrums. We have the challenge, though, from a regulatory perspective of proving things one indication at a time, because we see that there's a great value to a holistic approach, but one that is actually regulated and therefore can be prescribed with that level of confidence by providers that this is evidence-based form of therapy. That is exactly our thesis.
When you were using, Naim, you may know more about this, when you were using the app, were you able, because people become more relaxed about it and less medicalized, were you able to tweak out the actual alcohol use within and how much it played into the NAFLD and NASH? Or was that still very covert underneath it, I suppose?
That's a great idea, Louise, especially as we are speaking about a digital therapeutic and a lifestyle intervention. But I don't think we are able to uncover anything at this point. I don't know. I mean, this is more for Mark and Joe, and maybe thinking about something we can do in combination with questionnaires and patient-reported outcomes. Also, potentially some blood tests that we can do in our clinic and come up with maybe a different intervention based on the amount of alcohol being consumed. We're not doing this as far as I know, and Mark, correct me if there's a better way to do this, or Joe, if you have any ideas, but something to think about, honestly. And cognitive behavioral therapy, obviously, it will work for excessive alcohol consumption, potentially for some patients. So I like the idea, Louise. You're generating some new investigator-initiated studies for me here.
Oh, feel free.
You'll get your commission next time, I promise.
If you're patient enough until April, you're going to see both questionnaires and patient-reported outcomes as part of the platform. So we have been working for quite a while at making sure that they're evidence-based questionnaires that are associated to the best practices in the guidelines.
Well, I'm struck about the synergy with what you two guys are talking about tonight and my discussion with Tony Rahman in Brisbane and some of their digital and therapeutic interventions that they did before COVID and during COVID because of distance, and how well that process that you've got working together may work within an Australian type of system because of the distances. And a lot of the US, for example, some of it was synergistic with what's going on there, but probably you guys to certainly a higher level at the moment. But it just struck with me.
I just offer one other thought. I love the point that was just raised. And I think a lot of the potential ultimately comes down to building trust with people, that when you're working with people on any indication, if you have a therapeutic process that develops trust, then it gives you the potential then to uncover other really important things. I can't tell you how many times in clinic I would have patients referred to me for weight management or whatnot, and after developing a relationship with them, you would uncover something like a binge eating disorder or psychiatric illness that had never been diagnosed or properly treated. And so I think the art of this and the advantage of the digital form is that you can approach patients in a very human way, but in a non-judgmental, non-threatening way. And if you do that well, you have the potential then to develop trust. And once you develop trust, you then have the ability to kind of leverage, for example, as Joe mentioned, validated screening instruments that then may be able to help uncover, things that patients were ashamed to admit to their providers, but are willing to admit to a form of therapy or a form or tool that they have developed a relationship with and trust.
Louise, before I forget, I wanted to ask you about the app that you launched. Can you talk about it?
I can talk a little bit about it because it's not fully ready in a lot of other areas and we're just UK open at the moment. We've decided to just hold that while we get it out in a few more areas like Australia. Now, mylife365.me is not a medically approved digital solution. It's not dissimilar to what Mark was describing. It's more cognitive and prompting and nudge theory, but it puts you in control. Now, only 1 in 10 people, or less than 10%, are in the right areas. We want to try and help the other 90% locate their own risk. Now, that will allow us to, certainly what we see in Towers and Health, where people choose a lifestyle FibroScan, is that taking them off that pathway and putting them into medical care in the right areas earlier, who would have never normally been screened, but because you have a risk. I can think of somebody recently elevated FibroScan, didn't have any risks, then found out a direct relative had died of a liver disease, diabetes has now had their family screened, and 4 other members of the family have turned up with significant liver issues. That would have never been discovered till all 4 of those people or 5 of those people presented at end stage. So it's that type of thing we're more targeting. It's choosing to screen public health by the public. And with the MyLife365.me, because it's all about you or me as the person, because if I change me, I can change people around me, rather like your cognitive behavior therapy, Mark. You change the one person in the family, it resonates with everybody else. So it's very much about the demedicalization, because most people do not sit in a medical world, will never get access to it, but have the right to know. Again, first relatives. So we have a lot of people taking a lot of interest in, I just want to know more and be in control of my own health. I've got type 2 diabetes in the family, but nobody's going to screen me for this at the moment. So that type of come from the other way, squeeze it. Let's find the risks at different areas and give them to you guys in the healthcare environment. But again, we have people choose it because they're in healthcare and can't get scans enough. And it's one way to get access to FibroScan. The UK is currently the only place with Towers and Health and MyLife365.me that allow you to just access FibroScan and get a medical report that goes to your physician. So the physicians that receive them give us really good feedback to date where they've done that. So that for me is what we went to do, as well as from Towers and Health, mainstream medical healthcare, providing remote FibroScan for clinical trials, things like that, to make it easier. So that's where we currently sit in that space. But I'd say 80% of everybody who's engaged with their FibroScan and taken control improves their liver health. We know, irrespective of genetics, the best form of treatment is lifestyle, exercise, and being in control. So it is about empowering, which is what your app does on a medical side. People, they're not patients. Some of them will go on to be patients. That's the difference. This is about you and I, and it would be really interesting to just do a healthcare study of primary care physicians, because I get a number of them referring themselves for a FibroScan. We don't know it ourselves as healthcare professionals what our liver health is, and if we did, we'd engage a little bit more with the programs that Joe, you were describing, and Mark. So it's a different offering. It is, you come to us, you've got risks, let us help you. Help yourself and take control. My husband, who sadly can't be with us tonight, always uses the analogy of on an aeroplane, they tell you to put your face mask on first before you help other people. Let's take care of my liver first and know it before I can help others. So it's very much that way inclined, and we don't have advertising on it or anything like that. It is purely about you, with a catchy title, MyLife365.me.
Naim, thanks for the question. Louise, thanks for the answer. As I'm listening to what Mark and Joe, what you're describing, I'm wondering if these are things that over time are likely to evolve together. In essence, you know, Joe, you kind of have one rather large piece of this issue. Mark has a different piece of it. But are they co-evolutionary, or are they likely over time to, would you guess, to go off in different directions?
I think cognitive behavioral therapy has to be at the core of a treatment plan that eventually may grow into pharmaceuticals as new pharmaceuticals come along. It's not that they converge, they have already converged. And certainly cognitive behavioral therapy and a digital therapeutic as part of a platform makes a lot of sense. The real question becomes, how do you rise the patient from the underground, and how do you get the healthcare system to support a best practice that should be effectively supported but is finding headwinds with adoption? So they are already merged. The question is, can you find a business model that puts it all together in a well-packaged solution?
I tend to agree, and I also think these are very early days. Although we're all very familiar with software and the potential for AI, the reality is that we are at early days for digital therapies and digital tools. So there's a tremendous amount of evolution to be had. I mean, we've been building our product for 7 years, and we see tremendous potential to continue to evolve the capacity of the product and the AI that lives with it. But I think fundamentally, nobody wants a ton of point solutions. In the end, I think the evolution will be towards solutions that do integrate well and do form a system of care that takes a population medicine view that is really about designing solutions that are automated, pointed to the right person at the right right time, that takes burden off of the healthcare system, off of providers, that makes patients' lives easier and better, but in an efficient way. And I think that's the work that is ahead, that there's a lot of work to be done on integrating these solutions into health systems, into platforms, to really make that population vision really come to reality. We're at early days. So that'll be, I think, what's going to be super exciting about the next decade.
I'm going to add two notes. One is that Naim had to jump off. The second is when I said at the beginning, only American born, I was thinking of episodes we have that are largely populated by people living in the U.S. At this point in time, about half our episodes don't have anybody living in the U.S. except for me. The last time we had 4 people living in the U.S. on an episode where I was the only person born in the States, I think that's been a while. With that as a note, let me go back to where Mark was. Where you live now, so different answers for different people. Where is all this in 5 years? Would you guess? Would you hypothesize? Do you believe? Do you plan? Take the descriptor of your choice.
I'll go first and say that in terms of digital therapeutics, they are for the most part digital health solutions, let's call it that. They're for the most part living outside of the health system right now. And I think there's tremendous evolution that needs to happen in that realm. But what's going to happen over the next 5 years is that we're going to start to see digital therapies or digital medicines become integrated within the healthcare system and become part of the standard of care. And I would predict that within 5 years, several, if not most, of the cardiometabolic conditions like NAFLD or NASH will include digital therapies as an option, as a part of standard of care treatment, complementary to the hopefully great evolution that we see on the pharmaceutical side as well.
I think, Roger, that the term digital therapeutic will disappear because right now it's a great idea for a very limited scope application that seems to be spending a ton of time getting FDA approval under a paradigm that's more related to a molecule than it is to a computer program. When you try to apply for an FDA certification, you're going to have an on-label use for a digital algorithm that by nature should be changing constantly because the pace at which digital changes is much faster than the molecule, especially if it has no potential adverse effects to the patients, right? I mean, molecules are much more stringent on adverse effects, but, computer programs are much less likely to cause any harm, especially when supervised by the adequate provider. So what I think will happen is we will move away from the concept of a digital therapeutic into digital specialized platforms that are going to be helping health systems and providers take care of very particular conditions under an ecosystem that includes several things. An app, population health, medication, supervision, remote monitoring, all those things in particular are going to coalesce into programs that actually deal with certain specialized conditions. And those programs are going to be different according to the severity of the condition per se. So you will see different business models evolve around that. In other words, digital therapeutics is essentially a stepping stone into a new generation digital health platform.
I'm going to echo what Joe said with a combination of Mark, because I think what I would think I will see is that in 5 years, what you will get is the majority of common conditions that cross diabetes, cardiovascular, all of that side that require nutrition, weight loss management, CBT to change behavior will all be on one platform that every one of those referral specialities will refer into. So there will be a standardization that will be quality assured and KPI indicators that can tell you what patients are getting. And that should reduce healthcare costs because you get equality of referral into it across those divisions. So you get a standardized level of care, whether you're in endocrine, cardiology, hepatology, obesity management. And that, to me, is about the patient. The patient becomes key, the center, and the person. You treat the person with all of the commonalities, give them the best, and then you tweak out the areas you'll need. And I think the combination of what Mark and Joe are talking about healthcare and potentially what we talk about pre-healthcare, you can reach that. And that has a massive potential for healthcare, resources, use, and cost saving.
So, Jörn, how does that work in Germany?
That's a good question. First of all, again, I didn't get to speak up in this episode as much as I would have liked to. It was time restrained, but it was so interesting just to listen to you, Mark and Joe, and get Naim's hands-on experience on this. So again, I'm fascinated with the approach. So Joe said something, who's going to want to pay for this? And we were talking about a universal healthcare coverage here in Germany. You said that health insurance is going to be changed and they might not have an interest to invest in that. But the societal interest, it must be so big to invest in this because we want to stay healthy as a society. We want to use these people that we train and educate to live long and healthy. So I think there must be, for people that can afford it, I think they'll just buy it. So there's this way to engage with his own health and be provided. I think for the universal healthcare coverage, there is the challenge to provide the evidence-based character. Again, as Joe said, a changing algorithm, and that's really the strength of it. It's not going to be the same because it adapts to your lifestyle. Maybe the underlying code is the same, or I'm not sure, maybe you can approve a code or something, Joe, but you would know better than I do. And that's the challenge, and it goes towards prevention. That's what I said at one point. There's big programs key toward prevention. I think this is where it's going to fit in perfectly. So I would rather, instead of saying therapeutic, I'd probably talk about preventive measures. While, again, Mark, I agree, and you've showed in your data that you're capable of treating even potentially advanced disease cases.
What I take out of all this, besides the fact my head is spinning slightly, is that these tools are coming to a system that isn't currently best equipped to deal with them. So, Joe, I think what you're talking about might be the fastest adaptive path to get these kinds of tools into the system as it exists today, given some of the challenges around ranging from how drugs get approved to how specialists make money, right? I mean, this fights both those at the same time. And then when you go out to Germany, where Jörn, and just Germany, where Jörn has talked about the lower level of digitalization of health records, then you have a whole different level of coupled with universal payment, you have a whole different set of challenges. Joe, I like your vision that instead of talking about this as digital therapeutics, this is simply going to become almost a broader sense of digital health with a lot of things hanging off it at a lot of different levels. But it will be fascinating to see how this all evolves. It obviously has tremendous potential. We trivialize the term game changer all the time, but this certainly can be one or two or three, depending upon which games exactly we're talking about. But it will also be interesting to see how the established structure that isn't so well equipped to deal with this, Joe's example, I think about continuous improvement in digital health versus what do you do with molecules, and what does that mean regulatorily, is just a fantastic example of places where the structure as it exists is going to clash with the tools as they're created. A lot to see. We will keep following this over time. Mark, Joe, thank you so much for being with us today. And this won't be the last time we touch on this subject, or I hope the last time we have you gents back with us.
Our pleasure, Roger. Thank you so much for having us.
Absolutely, Roger. And all, thank you. This was a delightful discussion, and we look forward to continuing the conversation.
You're on, both of you.
And now for the Season 4, Episode 8 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. While I understand that my opening this section by discussing the Russian invasion of Ukraine this week is in itself potentially controversial, I try to steer clear of specific related controversies like things going on in the battlefield. So I'm simply going to say shame on Elon Musk and leave it at that. By the way, my good friend Mississippi Mick Colassa, whose song Recycle Me made an appearance on Season 1, Episode 15 of this podcast, is doing a fundraiser for the work that Chef Jose Andres and his World Kitchen are doing to feed Ukrainians early in March. Next week, we'll provide information on how to donate to Mick's fundraiser, possibly with another song from Mick for you to enjoy. In the meantime, let's pray for a just and fast end to this war. Slava Ukraini.
There may be more humanitarian fundraising in our future.
Listen here for an announcement next week about a program to contribute to people in Syria and Turkey displaced by the recent earthquakes. I'm hoping perhaps to have some kind of music or link to that one as well.
The NASH Tsunami download beat keeps setting records.
As I record this 13 days into February, we're close to 5,700 downloads so far this month. If no one were to download for the rest of the month, that would still make this number 10 out of the 35 months in our download history. Of course, we'll have more downloads, and this is way ahead of any other month's pace. It would be wild if a 28-day month became our most downloaded month in our 3-year history, but without jinxing things, it might turn out that way.
From the vault, some earlier thoughts about focusing on fatty liver as a multi-specialty, multi-metabolic disease.
This week's Vault episode comes from last April, Season 3, Episode 18.4, another episode featuring Jeff Lazarus with Jörn Schattenberg in the process of becoming a regular, and the three of us discussing in advance sessions 4 to 6 of the first Barcelona meeting, which took place later that month. The conference was integrative in nature, and this session focused on different kinds of integration. While there's nothing specifically digital in this brief talk, you can hear from all of us the need to pull multiple specialties together behind the idea that this is a metabolic disease, which is a multi-specialty, multi-element challenge in need of better integrating principles. I believe some of our conversation today about digital therapeutics and the whole digital health process talks about how we can use those tools to integrate.
We may be beginning to get reviews in here.
Next week or the week after, I'm hoping to have our first post-review interview happening, sandwiched between the NASH and business sections of this podcast. We already have the review. We already have the reviewer. Now it's all about scheduling. Please send us your reviews as well so you can join us on future episodes and more people can learn about you from us and learn about us from you. And with that, I'm off for another week. Thanks to Jake, Magic Mike, Eric, Louise for helping getting this episode out the door. I look forward to discussing underserved patient populations next Monday. Until then, enjoy the weekend conversations. Do what you can to help those whose lives have been totally upended by war and natural tragedy. And then stay safe, surf on. We'll see you on the podcast next week. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com and we will answer on the podcast or the website.